be your moderator today. I have the privilege of introducing and working for my dear friend, Dr. Boris Malugin, the designer of the wonderful device that has attracted so many of you here. I imagine most of you are here not for the lunch, but to hear about the newest generation innovation, the second generation Malugin ring. I also will be able to introduce a longtime old friend of mine. I emphasize old. That's Dr. Sam Nasket from California. So what we're going to do today is celebrate the life of our recently passed Dr. Boris Malugin. He has once again made a tremendous advance as the first generation helped so many of us. The second generation is even better. And I understand that it is now available. Is that right, Boris? Wonderful. And what I'd like to do today is to have 3 presentations that will show you our experience. I've been very lucky to work with MST. I've had the privilege of using the second generation lens for over a year. And I can tell you without question, it's going to be accepted and embraced by ophthalmology. It's a terrific device. I want to thank MST for buying all of you lobster tails and filet mignon for lunch. It's very kind of them to do so. And without further ado, I'm going to introduce the session with a short video on the Malugin ring and how I met Boris and my small contribution to his tremendous success. So can we show my little video that was published in the Video Journal last year? It was the best of times. It was the worst of times. It was the age of wisdom when a young Russian surgeon, Dr. Boris Malugin, trained by the renowned Professor Slava Fedorov, transformed the capsular capturing principle of a Soviet intraocular lens into a tissue capturing iris retractor. Dr. Malugin showed his brilliant idea to a young American surgeon visiting Moscow in 2005, and the inventor was encouraged to find an entrepreneurial partner to manufacture and commercialize the ring. The unique 4 scrolls and 8 points of fixation quickly overtook the Fry stretch technique and iris retractors as the preferred method for enlarging the pupil. That same American surgeon was privileged to design the companion scroll manipulator. Yet I had difficulty disengaging the large distal finger from the proximal scroll during the insertion of the ring, and it wasn't easy to engage the proximal scroll with the required vertical motion of the large finger during ring removal. I began a 2-year endurance contest to redesign the injector, thinning the finger and reshaping it so that the scroll could be easily released during the insertion. Then the scroll is transferred to the manipulator for a precisely controlled placement. When removing the ring, the tiny finger engages the proximal scroll, and the manipulator ushers the lateral scrolls into the injector. Here's an exclusive preview of the 3rd generation injector, which is a 1/4 millimeter more narrow and designed for insertion of a 5/0 proline rather than a 4/0 proline ring through a sub 2 millimeter incision. The ring and insertion tool are currently unapproved. For removal, the distal scroll is free. Next, the manipulator frees the lateral scrolls. Lastly, the proximal scroll is free and is best supported on a bed of OVD. The new finger, which now accompanies every ring, has simplified the insertion and removal procedure, which makes surgery better for the patient and surgeon alike. Although their respective countries are sometimes in conflict, the Russian and the American have made a very good team. So now I'd like to show you a case from this past week. This is a patient who had superficial keratectomy for anterior membrane dystrophy, had a long history of Flomax with terrible complications in the fellow eye due to IFIS. And I had the chance to see this patient and schedule the second eye. Now, the first thing that I do is I raise the iris off the anterior capsule, and I'm using Healon 5 to do so. I've also got some dilatation from viscohydriasis. But one has to lift the iris up to make it easy, and then it can be very easy. I make a second stab so I can lift up the subincisional iris off the anterior capsule. And now I bring in the injector, which will go through a 2 millimeter incision. This is a 2.2 millimeter incision. And the new ring, which will enter the eye. It's no longer 4-0, it's 5-0. The scrolls are a little larger and easier to engage. The ring is more compressible, and it is very easy to insert. There's a lot of different methods, and I'm sure Dr. Malugin and Dr. Maskett will show you their own preference. This is a manipulating instrument, which I find very easy, and you saw the new injector. I center the ring, and then after the lens is injected, it's time to take the ring out. Now notice the sequence. There's two choices. In this case, I take out the OVD first. From behind the lens, I put in more OVD, and then I disengage the distal ring. Next, I like to disengage the right and left rings, and you'll see differences among each of us. That one I can't see. It's under the little blood, so I just move it and then engage it and place it on the iris surface. The most difficult scroll is the proximal scroll. So once I engage it to prevent it from rebounding under the incision, I push it forward into the OVD, and I put more OVD next to it. And that freezes it where it will be very easy to go underneath the scroll with the platform, bring out the little tiny finger, which I love, engage the scroll, and then I'll put a second instrument in, and I'll simply help these two rings, because see, it does get hung up sometimes. So I press it down, and it's very, very atraumatic. And here's the eye at the end. And unlike the cover of the JCRS last month, these pupils look excellent. That was a very unfair article, which I would like to address in a minute. But let me show you this case. I've got two additional cases that are much more difficult. This is a lady who has mild Alzheimer's disease, a very small pupil. Her Alzheimer's disease is about the same as mine. She has nanophthalmos, so I always compress the globe in nanophthalmos to dehydrate the vitreous. It's very important to do that. She's had peripheral iridotomies for angle closure, and she has an anterior chamber depth of 1.5 millimeters. It is said that you can't put a Malugin ring in, but that's not true. I create the space by mannitol and by digital massage, I lift the iris off the anterior capsule, and then I put in the ring. And you, look, see, I missed that. It's okay. There is no Olympic judge penalizing me for missing the scroll. I just take a second try. I've never seen anybody put in the Malyugin ring perfect every time except Boris. And that's because he never shows the ones that don't go well. I do the rhexis in this patient, and this is going to be very interesting because I'm hydrodissecting the lens, and then the patient decides she wants to leave. She's had enough. So she's disoriented. The anesthesia people gave her too much anesthesia, and she doesn't know where she is. My scrub nurse falls over onto her chest to keep her on the table. And I wish you could hear the sound because I'm being very reassuring. I'm saying, please give me anesthesia. And we calm her down. And that's one of the problems we have with anesthesiologists. They want to help us, so they put our patients to sleep. And that's terrible when you've got an elderly, so they say, go ahead, Dr. Osher. So I'm going to go ahead now. I'll continue the case until she leaves for the second time. So this time, I say, give propofol. And the anesthesia person looks at me, he says, that's what killed Michael Jackson. I said, if you don't give it, I'm going to kill you. So now he gives the propofol, and the patient becomes tranquil. I can use my bevel down phaco tip to work under Halon 5. I direct the energy backwards until I'm deep enough to sculpt at very low vacuum. So I leave the OVD in the chamber. I separate the lens into two hemispheres. This is a hard lens, hard by American standards. And then I'll bring each apex into the middle of the pupil. I use the bank technique, which I always have a bank of the adjacent quadrant next to where I'm working, which holds the capsule back. I'm working a little bit more tremulously than I usually do because this, as you can imagine, was an adrenaline-provoking experience. I quickly inject her lens and place it into the capsular bag, and then I'll remove the Malyugin ring. Boris, I don't know what I would have done if I had iris hooks or something else in this case. The ring really made it easy and very fast. I'm not a fast surgeon by any means, but in this case, I went as quick as I can. You can see that I did. This patient, by the way, is on Rapaflow, which is just like Flomax, but worse. So the iris doesn't look as good as I would normally like it to look, but still, she has a safe lens, and because of her Alzheimer's, I'm going to seal her incision and take no chances with her rubbing her eye. She's also on anticoagulants. And you can see that the eye looks quite good the next day, except that's the preoperative photograph. So somehow we've got this in the wrong. Okay, that's okay. This isn't, keep going, please. This is a patient from Chicago who has also, I'm showing you two cases of nanophthalmos. This eye is a very small eye, 20, I'm looking here through my notes, This is a 20 millimeter eye. Look how I sweep the peri-bulbar away from the incision. And when I sweep the peri-bulbar away, it lets me put a good incision, removing that subconjunctival anesthesia. I like to make a groove. I go uphill with the diamond. I go downhill, and I flare the inside. So I'm 2-2 on the outside, 2-4 on the inside, and that little flare is great. Now the eye wants to collapse because it's nanophthalmic, and I'll perform the synechialysis next. Notice that there's a nevus there. I forgot there was a nevus there, as you'll see later in the operation. I raise the iris off the anterior capsule. This patient has also had a peripheral iridectomy, which you can see up by my instrument for the angle closure. These are very difficult cases. David Chang published some time ago how you go through the pars plana to remove some vitreous. I've never had to do that. Plana is. Every retinal specialist will tell you that. So if you give mannitol 20 minutes before, and you press on the eye with a muscle hook against the bony orbit for 5 minutes, the eye is mushy soft, and then when I put in Healon 5, I have a nice anterior chamber to work in. Again, look how easy it is to put in the Malyugin ring and the beautiful exposure you get with this new ring. The old ring was fine. And this ring, I believe, also comes in 2 different options, probably 6 and 7 millimeters. I refill the eye with OVD, and then I use my bevel down phaco tip from Alcon. I have no financial interest, but it keeps the OVD in the chamber. The OVD doesn't get to the probe, and then I turn the probe over, and I sculpt deeper with lower vacuum so I don't pull the OVD into the groove. There's a lot of ways to do phaco. Everybody has to come up with their own system. And this is my preferred technique. Very different than Boris and Sam, I'm sure. So, it's not a difficult case anymore. We took care of the nanophthalmos, we took care of the small pupil, and now we're taking care of the hard nucleus. I usually will chop. Sometimes I'll use that technique. Every case is a little bit different, but the important thing is that the principles are respected. And the first principle in surgery is to make the pupil big enough so that life will be beautiful. And the surgery will be safe. So I take the subincisional cortex always under the incision first. If you wait until the very end, where it's the most difficult, the bag wants to collapse, the chamber wants to shallow, it's much more difficult. Do it first. And then I vacuum the entire capsule, which is very safe with the soft tips. And then I inject the lens with autocert. And this will have a different sequence. In this situation, I took the ring out first. Sometimes I take the OVD out from behind the lens and evacuate the bag if I think the pupil's going to become myopic. If I think the pupil's going to stay reasonable, I might just take the ring out first. That's up to you. I think the best way is probably to empty the bag and then put in more OVD to take the ring out. And you see how easy it is to take the ring out. I've heard surgeons say it's difficult. I don't find it to be so. And then I hydrate the incision and then I'll take out the OVD. I always hydrate the incision with this sequence before I take out the OVD, because I don't want the chamber to shallow. But if you're taking a ring out, I don't hydrate first, because then I couldn't get the ring out very easily. And then I've got the synechii from the angle closure. And I'm going to do a peripupillary membranectomy. And this is where I kind of become hypoglycemic and I make a mistake. But you'll see the mistake in a moment. I love stripping the pupil. The pupil will dilate so nicely. See the Flomax? Look at that. See that? Ah. So maybe I should have taken out the OVD first in this sequence. But now what I want to do is I've got this synechii, and I want to take out the synechii. So I forgot about the nevus. So I'm going to spend a little bit of time trying to take out the synechii, because I'm so terribly obsessive compulsive. It's a real disease. And see, there is a synechii there, but there's also a nevus. And I think I tried to remove them both, which clearly didn't work. So I strip out the synechii, and then I take out the OVD. And here we are at the end of the case. I showed that twice because I wanted to say I turn off the infusion. Always turn off your infusion before you come out if it's a IFIS case. Then the iris will never prolapse. And I put in a miotic here. You can see the synechii. I press on the incision. And this was about, a year and a half ago. And again, I see this pupil is notched. Many times the pupil doesn't even look operated, but this was a bad iris with synechiolysis, peripupillary membranectomy. And I'll close by saying that if you saw the cover of the JCRS, it compared a new pupil expanding ring to the Malyugin ring, and it showed that the Malyugin ring did not give as good a pupil. I would have never accepted that article. One case, and they accept that article. It's ridiculous, because we all know that surgery is dependent upon surgical technique. And I would go on record saying that gentle surgical technique results in a much more beautiful pupil, time after time, than the cover of the JCRS implied. So I wanted to throw that editorial in. Boris, I'm so happy that you invented this ring. I'm so grateful you included me. It has helped me countless times. And I'm a much better surgeon because of your innovation. So with that introduction, you all know Dr. Malyugin. He really doesn't need an introduction, but the inventor of this grace device, my dear friend from Moscow, Dr. Boris Malyugin.
Thank you very much, Bobby. That was a great show, and I really appreciate your techniques. I always learn something new from you all the time. I see your videos. That was great. So what I will be talking now today is maybe a little bit hot topic. We know that the femtosecond cataract surgery arrived about 8 years ago into the clinical practice. And of course, by introducing new technologies, sometimes we are introducing some issues. We know that eyes with small pupils are challenging, and this is definitely related to these particular cases. And of course, we know that there are many other options to expand the pupil, and we will be focusing on one of these options, the Malyugin ring. Just briefly to remind you that the original versions came with two sizes, 6.25 and 7. I personally like 7 for IPS cases that were nicely shown in previous videos, and 6.25 for regular cases, myopic cases, fibrotic, uveitic, when you don't want really to expand the pupil too much to and overly traumatize the iris and to avoid notches postoperatively. But talking about small pupils and flex, when we start doing flex in my clinic, so that was a very unpleasant finding that when the patient arrives to your operating room and you see that the pupil is small, and then you have to do something to expand it. And actually what I've seen in my clinical practice that the phenylephrine, which I use very frequently, almost all my cases, does not work very well in these cases as compared to the regular cases. So it's less effective even if you inject phenylephrine into the anterior chamber in this particular patient. So, and there are a couple of publications showing that there is intraoperative meiosis that may occur during femtolaser cataract surgery, and we know that actually we need to keep the safe distance, and the safe distance in between the edge of the iris and the capsulotomy is somewhere around 500 microns. When you keep this distance in this particular case, you end up with the pupil, with the capsulorhexis size which is 3.5 millimeters, which is definitely not acceptable to do the cataract surgery, not enough to do the cataract surgery. So we also learned that in initial cases we've got 25 to 30% of meiosis in between the two steps, laser and surgical step. But luckily, when we are using non-steroidal anti-inflammatory drugs preoperatively, combined with the phenylephrine intraoperatively, we can reduce these numbers by 3 to 6 times, up to 5 to 10%. And that publication showing different non-steroidals used for these cases, and you can see there is a huge variability of the results that happens in these cases, and this is from 1.65% of cases up to 90% of cases, depending on your pharmacological protocol. So you have to keep in mind that we need to adjust your routine pharmacological protocol. And of course we can use hooks with laser, but as you can see here, the aspect of the hook going out of the wound does not allow you to dock very effectively. That's why it is possible to dock the laser to the eye with the hook going out of the eye, but it's a little bit challenging and definitely not very pleasant for the patient. There is a study from Burkhard-Dickert group showing that approximately 5% of his cases initially coming to the flex procedure went with the small pupils, which were judged as pupils less than 5.5 millimeters, and they were gradually going down to pupil expansion device that was actually used intraoperatively. So the second generation of the ring, which is made of 5-0 polypropylene, it's much more flexible, it's easy to use and easy to insert and to remove from the eye, and that's why this type of incision, which is 2.0, it's quite acceptable for me to use in femtosecond cataract surgery, because I'm pretty much sure that this size of incision will be watertight during the docking phase of the procedure, during the laser phase of the procedure. So as you can see here, I created only this 2.0 millimeter incision, and then implantation of the ring, and then I send my patient under the femtolaser. And as you can see here, by injecting viscoelastic, because I would love to leave viscoelastic in the anterior chamber to keep it stable, and then you see how capsulorhexis is being created. We can see it on the laser screen, and we can see that the anterior chamber is deep enough, and you see characteristic view of the iris, showing that the ring is there. And also you can see the pattern of, that is created by the laser. And this procedure became more or less routine. So patient was sent back under the operating microscope, and his cataract was removed, and now I'm aspirating the cortical material from the capsular bag and implanting IOL through the same unenlarged 2.0 millimeter incision. And it's time, of course, to remove the ring at this particular point. And similar to what was shown by Bobby, I like to disengage distal scroll first, following by proximal scroll. And I usually do not disengage lateral scroll because I don't think it is really necessary, because when you are retracting the ring, it goes in and disengages from the iris quite easily. And this is the end of this case. This is another patient with the history of pseudoexfoliation syndrome, and this was a patient intaking tamsulosin, and we know from several studies that if the patient having less than 7 millimeter, he have fourfold chance of creating of having intraoperative floppy iris syndrome than the regular patient with the pupil size which is over 8 millimeter. So again, a 2.0 millimeter incision was created, and after injecting viscoelastic, and then I injected the ring, engaged the distal scroll, proximal scroll, one of the lateral scroll, and then again I'm positioning the ring, centering, and then sending this patient under the laser. And of course you can be sure that capsulorhexis can be 4.7 millimeter or 4.8 millimeters in diameter, because the ring provides you enough space and help you to maintain the distance in between the edge of the iris and the capsulorhexis, because we don't want to damage the iris with the laser. And as you can see here on this picture, that in this patient the anterior chamber is even deeper than in the first case. This is because this is my patient. First, when I do submit the patient under the microscope, I have to check my capsulotomy, I have to release the gas, I have to do hydrodissection, and then pre-treatment with the laser helped me to remove the lens quite effectively, and then I inject IOL and remove the ring. So I'm actually was playing with the different variations of lasers, and this is a patient that came to me from the laser. You see, the laser was already being done. This is the patient with corneal transplant, where I was planning to implant custom-made IOL, and as you can see here, the pupil is very small. It was possible to enlarge it a little bit by utilizing intracameral canilaframe and heavy OVD, but still the pupil is not enough to proceed with the surgery. So we need to expand this pupil, we need to insert the ring and to expose this capsulotomy. As you can see here, there is a nice capsulotomy made by laser. We can see radial cuts on the lens. Then we have to check whether the capsulotomy was good, because when you're not certain, it's a good recommendation made by Zoltan Magid that you follow the contour of the capsule with your forceps, just to be sure that there are no tags and there are no residual adhesions in between the capsule and the capsulotomy flap. And as soon as you've done that, then you're more or less okay, and then we remove the lens and inject this custom-made 12 diopter cylinder IOL into the capsular bag. And it's very important when you implant this toric IOL, it's very important to place this lens properly. And we need a good pupil to be sure that the lens will sit in the right direction and the alignment is correct. So again, I'm not disengaging lateral scrolls to save some time, and then just disengaging distal one, proximal one, and then I'm guiding with both lateral scrolls when they go inside the injector tube, and this is basically the end of the case. So this is another laser platform. We were playing with different laser platforms. This laser platform helps you not to move your patient away to the laser step, so you can do it on your operating table. So because this is a mobile femtosecond unit, and you can do everything in one step by not moving the patient, which I think is a great advantage of this step. As you can see here, the pupil was more or less okay during during the femto step and during the initial steps of the procedure. So I was doing my routine steps of phaco surgery by aspirating the cortical material, by aspirating cleaning the anterior surface of the lens, and then I try to follow the cleavage planes that was created by laser, and following these planes in order to disassemble this nucleus. But look at this paracentesis. So the pupil starts prolapsing through the paracentesis. It starts constricting during the surgery, and this is definitely intraoperative floppy iris syndrome in these patients. I still was thinking that I would be safe enough to conquer this pupil, and by injecting viscoelastic through paracentesis, you can a little bit expand the pupil, but as you can see here, there is a constant constriction of the pupil throughout the procedure. That was definitely the result of this intraoperative floppy iris syndrome combined with laser generating prostaglandins in the anterior chamber. And finally, I was a little bit nervous at that point because I was thinking that maybe I will damage the iris, and then that's why I thought that it's time to inject the ring at this particular point, because we need really to expand the pupil. But before that, I was thinking about irrigating, aspirating at least some of the cortical material, which was done in this case, but then I thought that probably ring will be much safer. And as you can see here, this was an interesting step of this procedure. After injecting the ring, this scroll was disappeared, and I was pretty much sure that it was dislocated. But look at that area, so it was perfectly in place. This was the fold of the iris going over the scroll and showing how biomechanically unstable this iris is. So then, as soon as the ring was in place, the rest of the procedure was more or less routine. I was aspirating the cortical material. This is a dry aspiration step, and then followed by IOL implantation into the capsular bag and removal of the ring. So this is another clinical case with the same laser platform, where I decided to go on and inject some viscoelastic, expand the pupil with the ring, and again send the patient under the laser. So I like to position the tip of the injector very close to the iris, because it helps me to control when I'm engaging the iris. And there is no shame not to be able to engage both lateral scrolls, because you can actually tilt a little bit the device, you can tilt a little bit the injector in order to place it in a more proper position. This is a 7mm ring, because second generation of the device also goes in two sizes. And I choose 7mm ring because I was thinking about this for these cases to be managed. And as soon as the ring is in place, I inject more viscoelastic, I dock the laser system, and then I attach the handpiece of the laser. Before that, I put some water, and then I attach the laser after the undocking. And then, of course, we need to create two paracenteses. I like to make them corresponding to the, sometimes it may still happen. And then release some gas bubbles from the posterior surface of the lens. And after that, the procedure became more or less routine. I'm following the cleavage plane, releasing the air from the bag, and then removing this lens and implanting the new one. To summarize, there are some publications of using this device in the literature, and there were some reports regarding incomplete capsulotomy related to the viscoelastic that was left in the anterior chamber, which is a little bit contrary to my personal experience, because with the combination of chondroitin sulfate and natrium hyaluronate, we never had experienced any issues with complete capsulotomy, and we know that OVD, even having a higher refractive index as compared to the aqueous humor, does not really much deviate laser beam, and it is within the range of the capsulotomy that we would love to have. So to conclude our experience, it was shown that Meridian Ring, the second generation, is very effective in femtosecond laser-assisted cataract surgery. It can be used in different laser platform, can be implanted prior to flex using dispersive viscoelastic, and provide stable, safe, and reliable results. And I thank you for your attention.
Of a very timely, contemporary topic. I would caution you that if you're going to put a Malyugin ring in the middle of your case, because the pupil has constricted, it's very easy to inadvertently engage the anterior capsule. So you must be careful not to engage. Well, sorry about that. I didn't know Sam was going to talk about it. I usually try to give his talk for him. Listen, if the Olympics were still being held in Brazil, and they introduced a new event like cataract surgery, from the United States, I would have a very short list of surgeons who I would be proud to send. And Sam Maskett is on that short list. He is a very thoughtful, very careful, very kind ophthalmologist. And I'm delighted to be able to introduce him as such, Dr. Sam Maskett.
Thank you, Bob. Good afternoon. I hope you're all managing and eating. I hope you like your chicken sandwiches. I thought they were very good. Let's click me on. Well, I'm going to look actually at some different tools, different techniques, and we'll see where we can apply them. And without question, small tools can really offer big help, particularly the ones that we use for our intraocular manipulations, a whole host of things that MST and others manufacture for us. This is a patient, this is a challenge. An hour before I saw this patient, she was a very happy woman. She was being treated for recurrent submacular choroidal neovascular membrane, repeated anti-VEGF injections that retained good central acuity. However, this particular morning, after the retinal surgeon injected the medication into the vitreous, intraocular pressure is elevated. You put a 30-gauge needle at the limbus to lower the intraocular pressure. And the story varies whether she looked or she didn't, but the net result was that this represents a laceration of the anterior capsule, and this is the track that the needle made going into the lens. Posterior capsule is intact, and she's sitting there with her attorney husband breathing down my neck. And to make the case a little bit more challenging, she's been a moderate myope her entire life, wearing -550 glasses and no contact lenses. And you can debate whether it's better to watch this or whether it's better to approach it. My concern was any changes in the lens material might severely challenge our ability to do anything we'd like to do with this capsulotomy. We cannot use a femtosecond laser to try and get around this. So we have only really a series of tools that can help us. So after capsule staining and under OVD, going through a nasal paracentesis, I was able to use, this is the sidal modification, of the microcapsulorhexis forceps. And I could just grab it enough and then do just a little bit of a Brian Little maneuver, bringing the capsulotomy back in the direction from which it came. And once I was able to do that, I could at least start the capsulorhexis without it going further out into the zonule. And then coming around from the far side, going back into that nasal paracentesis, I was then able to get around it and complete a continuous, not circular, but a continuous anterior capsulotomy. And this is what she looked like some 6 months after surgery. And you can see the inferior extent of the anterior capsulotomy went this far, but she had a continuous capsulotomy and life was good. I aggravated very significantly how to do that, and I think that tool really helped us. We spent a lot of time talking about Boris's incredible device, and it really has made life so much better for all of us. However, is we can't always use it. We're going to look at a couple of situations where I felt we really needed hooks rather than the ring. We've not discussed this single-use IA called the Allegro, which is the most capsule-friendly device I've ever seen, which you really need when you consider dealing with a patient of this nature. This is a classic posterior polar cataract in a 38-year-old woman with a lot of changes around the opacity, and that sometimes signals a defect in the posterior capsule. I think a very strong case can be made for using femtosecond laser. In these, I don't divide the nucleus, but this gives me the capsulotomy exactly where I want it, so that if I do have a defect in the capsule, I can use the anterior capsule for capturing. This is hydrodelineation, not hydrodissection. And because she's 38, all we really have to do is aspirate with almost no ultrasound the endonucleus. Now, my particular strategy is after I remove the endonucleus and before I take the tip out, I do with a dispersive visco agent, I will go underneath the capsule and do viscodissection of the epinucleus and cortex so that I can separate it. We've not done hydrodissection at this point. So here goes the OVD under the capsule in several places. And notice that the phaco tip is still inside the eye because we don't want chamber collapse in the case that the posterior capsule is either very defective, potentially defective, or already torn. So here's the OVD going in, and then we can take both instruments out. Now I like to reach out and get the peripheral cortex, leaving only the posterior plate in place, so it's the last thing I take off the capsule in case that little opacity is really a cork on the open capsule. But notice here the pupil is coming down. Again, this is a post-femtosecond laser patient. Now, as Bob just mentioned and teed it up perfectly for me, once you've already done a significant amount of surgery in the chamber, it's extremely difficult to avoid the capsule if you want to put in the ring. If you've used a stain, it makes it a lot easier, but you can't stain at this point. So, to me, the use of hooks in this situation is safer as a secondary thing, so I tend not to use the ring once I've already done a significant amount of nuclear cortical removal. Now, as it turns out in this case, the capsule was intact and life was good, and all these maneuvers weren't necessary. However, the capsules, remember, can be as thin as 3 microns or even less, and so I always practice this technique in anyone with a posterior polar capsule, even if I don't suspect a defect or pre-existing defect in the capsule. And I don't polish the posterior capsule. Here we're just setting the patient up for intraoperative aberrometry, after which we'll place the intraocular lens. I think we can move on from here. But you can clean the anterior subcapsular LECs without any hesitation. And I strongly urge you to do that in every case. So we leave the posterior capsule intact. And here's a patient who had more than 20 years earlier an industrial injury with a perforating injury on the limbus around 4 o'clock. And he has this pupil pulled into this area. And he's actually been very happy with his life and with his vision until a central nuclear cataract increases glare and reduces visual function. And here at surgery, we're marking the size of the capsulotomy we'd like to make. But note the pupil. Now the pupil is eccentric and it doesn't have an intact sphincter. Placing some dispersive OVD over the area of open zonule. But notice the pupil is still not adequately sized. And there's no way you can place a ring in this case. It's technically not feasible. So this is another perfect example of where you can benefit from the use of iris hooks. And so I tend to use them in this situation. Here, fortunately, in doing the capsulotomy, I was able to discern that the zonule was strong, and I didn't anticipate any further zonulitis during surgery. As we come out, always in a case like this, we put in OVD, and again, we'll extensively clean LECs so that we can prevent postoperative capsule contraction. And it's good to be able to see what you're doing, so the iris hooks are helpful here. Given that I was going to plan to sew the iris and create a centralized pupil for the patient, I thought best long-term to place an endocapsular tension ring, and so that was done. And then with a little bit more cleaning, and then we'll place the lens. Like Bob, I absolutely believe in cleaning out the OVD from behind the lens before you remove the ring. I think I do it in virtually every case. And I'll do the same thing here with the iris hooks. And then if necessary, I'll place more OVD in front, as we'll do here, so because I want to manipulate the iris. So OVD will go in front. So here's a microforceps, and this is a 10-0 polyester suture, and we're going to close the pupil down in order to centralize it. You know, interestingly, even though we tolerated the eccentric pupil infratemporally for so long, in the phakic state, because of the size of the lens, would be no problem. But in the pseudophakic state, absolutely would not be tolerated. So you have to centralize the pupil. And here we have intraocular tying instruments, intraocular cutting instruments to cut the sutures, and we're using the standard Symposium method here to close down the iris defect. This will create a pupil that is not normal in shape, and so the job isn't done by closing the pupil defect. The job will require the use of the vitrector to sculpt the central pupil, and it actually works very, very nicely. So once again, one more suture through the more central pupil using microforceps to help us. And if you're unfamiliar with the Symposium technique, Alcon has a wonderful teaching video that Gary Condon made for them. And here at the end, I'm going to use the vitrector to just nibble away pieces of the sphincter in order to make a small, round, and simple pupil. Unfortunately, the vitrector misses a little bit of the scroll there, but the pupil is nicely centered. And again, here at the end of surgery, we'll check to make sure that all incisions are hermetically sealed. Post-operatively, I missed a little bit of the iris scroll with the vitrector, but you get the sense that you can create a round central pupil, and obviously this is very helpful to the patient rather than having that infratemporal defect. You went on to have normal post-operative vision. I'd like to spend just a moment talking about MST capsule hooks. These come forth with package. Now, I didn't put the new version on this slide. I think it's really essential that you understand what modifications have been made. But one of the things that can happen inadvertently is that if you feed a capsule tension ring into the eye with the old hook in place, you can feed it through the hook, and that creates a very difficult situation where you have to cut the hook and try and feed it around the endocapsular tension ring. So, MST has modified this, and you should stop by the booth and see it, where these are much closer together and come to a wall at the bottom through which a capsule tension ring will not fit. In the interest of time, I don't think I'll show the use of these devices, but we can entertain some questions from the audience, and I thank you very, very much for your attention.
set Sam up? Well, he just set me up accidentally, because on this issue of the video journal, which we finished this week, it's got all the different seeps or suture techniques. It's got all the widening pupils, all the constricting pupils, all the other topics on pupils, and you can get this for free after 32 years of editing. Every issue is 90 minutes, 60 to 90 minutes. There's no advertising, it's pure education. And I'll leave these up front. You can look on the back of the table of contents, and it tells you the code, 4847. Do not pay the $200 unless you want to, and I will leave these up front. More importantly, I'd like to close by telling you that we have a course that teaches all of these techniques. Dr. Malugan came last year and taught all the intercapsular techniques in our labs. 3.5 days in Florida. We go from 7 in the morning till 11 at night. And all the suturing techniques, the seeps techniques, you name it, they're in this course. It's Dr. Dick McCool, Warren Hill, Ahmed, Doug Coe, just the best teachers you can imagine. And for 3.5 days, from 7 in the morning till 11, nothing but it's pearls. So I'll leave these up here on this Florida course. It's very cheap, it's very safe, it's very enjoyable. I want to thank Dr. Maskin, I want to thank Dr. Malugan, I want to thank MST for providing another wonderful lunchtime symposium. Have a great meeting.